friends. Today we are going to discuss about cognitive behavioral therapy for hypochondriasis. I have already made a video on hypochondriasis, the clinical signs and symptoms, diagnosis, comorbidity, prevalence and treatment. The video is already recorded and it is available on my YouTube channel. To know more about hypochondriasis, please do visit my YouTube channel. I'm Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be specifically discussing about the cognitive behavioral therapy for hypochondriasis. What are the steps and process will be discussed in this video. Cognitive behavioral therapy was founded by a psychiatrist named Dr. Aaron T. Beck. He is considered to be the father of CBT. He brought in a dimensional shift in the way we do psychotherapy by bringing in a new concepts and how structured psychotherapy is done. Let's look into the hypochondriasis now. The hypochondriasis means an excessive preoccupation with the possibility of having one or more diseases, which can be progressive or life-threatening. It is also associated with irresistible urge to repeatedly check for physical health or to seek reassurance that they are not suffering from any illness, either by a physician or by lab investigations. Many a time, they do Google and also AI-based search to know whether they are suffering from illness or not. In simple words, hypochondriasis means fear of having an illness, my dear friends. So, imagine if you feel that you are having a cancer and what are the symptoms you are going to face. That is what is hypochondriasis. If you look at this diagram, you will see the first and the foremost dimension is worried about having or getting a serious illness. Invariably, having an illness is hypochondriasis. The possibility of getting an illness, invariably it is obsessive in nature. It can be considered as OCD. You need to differentiate between OCD and hypochondriasis. But fear of having an illness is clearly hypochondriasis. Further, once they have this fear of having an illness, they will have severe anxiety. What will happen to me? What if the diagnosis is true? So, how many days I'm going to live? So, there are various anxiety related thoughts, anxiety symptoms will start occurring. Many a time, even the doctor has done the investigation. They did CT scan, MRI. They are all negative. The doctor will say you don't have any cancer or any illness, but still the patient does not get reassured by negative test results or by the reassurance by the doctor. That is the classic of hypochondriasis. Further, they also repeatedly check their body for signs and symptoms of illness. So these four important elements forms hypochondriasis. Here in hypochondriasis, the problem is not the presence of bodily sensation. Invariably, they will feel uncomfortable sensation in the throat. Example, they feel that they have a cancer. That throat can be because of infection or maybe an abnormal sensation. Here, it's not the abnormal sensation, it is the meaning attached to this abnormal sensation, that is catastrophic interpretation of this sensation is highly pathological. And this pathological belief is maintained further by cognitive distortions, rigid schemas, and automatic negative thoughts. So the hypochondriasis revolves around fear of having an illness that stems from an abnormal sensation and catastrophic interpretation of those sensations. But if you look at the health and illness belief spectrum, you can see some people are very worried about their illness or their health or maybe about the illness. Let's look into this spectrum. Here is a spectrum concept of illness anxiety. At one hand, you can see health conscious. He's very health conscious. He gets up in the morning, goes for a jogging. He's conscious about health. Next is he's concerned about his health. Concern, I may fall ill. That is the health concern. Third one is he's obsessed. I should eat this much only. They will start counting calories, whatever they eat. So that is health obsessed. Illness anxiety starts now. Here the hypochondriasis starts. A neurotic part of anxiety, and finally the psychotic part of hypochondriasis, that is delusional, psychotic belief that I have cancer or have tumor, I have HIV, I have rabies. So in this, if you look at this, this is one is health related, another one is illness related. So hypochondriasis is illness related. They are worried that they are not worried about their health, they are fear of having an illness. That is, one is neurotic spectrum. Yes, they believe they may have an illness, but it is shakable. But whereas a delusional one, hypochondriacal, is the issue. Here, as you move from one end of the spectrum to another end, there the impairment starts increasing. Initially, there will be no impairment in the health related. As the illness related goes towards the psychotic part or the delusional part, there will be severe impairment in their social function, biological function, and occupational function. Now let's look into the classification of hypochondriasis. So Busky and his colleagues have differentiated hypochondriasis into primary and secondary. Primary means illness anxiety. There is no any other illness. This is a de novo. This is the first time he's having that he has a fear of having an illness. That is primary. But secondary means it is secondary to some other illness, secondary to psychiatric illness. What is that psychiatric illness? You may have psychotic depression. In psychotic depression, the patient may start telling that my intestines are rotting. In schizophrenia, the patient may say that somebody has put a tumor in my body. Delusional disorder kind of thing is I have got a tumor in my brain. So in panic disorder, patient may start believing that they have heart problem. So these are all psychiatric, secondary to psychiatric illness. They have hypochondriacal concerns. Medical illness. Invariably, if a patient has a benign tumor, he will be very anxious. He believes it may become cancer. Or else a person has already been recovered from cancer, he has been treated, but still believes he may get cancer or still there are cancer cells. So these are all again secondary concerns. And the third one is major life related stress. One is medical student syndrome. For example, many of our psychiatrist students, when they join first year, when they go through ICD or DSM-5, they feel they also have this. When they read depression, they feel that I have depression. When they feel schizophrenia, they feel that they have schizophrenia. When they feel delusional disorder, they feel that they have delusional disorder. When they read bipolar affective disorder, they believe that they have bipolar affective disorder. So this is a medical student syndrome I may also have. Suppose if that is another one is loved one having the illness. For example, father dies with a heart attack. The child also believes that I may also develop heart attack because my father and I also have shared genetics. So these are the secondary and also sometimes grief related. Caring for a terminally ill patient also feels that I may get the same illness. So these are secondary. But here today we are discussing about the primary, that is illness anxiety, my dear friend. So if you look at the way the vicious cycle of hypochondriasis or hypochondria revolves around. First is the internal trigger. What is internal trigger? Whenever a person has abnormal body sensation, it can be any sensation. It can be normal sensation sometime. It can be very abnormal sensation also. Whenever they have an abnormal sensation, they believe that they have some illness. Or else external trigger. Suppose a death of a family member by stroke. Then they believe that they may develop stroke or they have a stroke. They have a weakness in the right hand. They believe that they have stroke. So these internal trigger and external trigger, they start believing they may get an illness or they have an illness. This leads to anxiety and fear. This anxiety further increases bodily sensation. Imagine if you have anxiety, you have panic attacks. It's once they have a panic attack, then they feel that my heart is going through some wrong thing and I may have heart attack. And again, further, they increase this misinterpretation of the bodily sensation to a severe illness. And they start again checking, reassurance seeking, going for doctor shopping, doing lab investigation, doing internet search, reading medical literature. And whenever they read, and sometimes they may get a temporary relief. But the hypochondriasis continues, my dear friend. This is how the vicious cycle of hypochondriasis goes on, and they get into this loop. and the patient will have biological, occupational, and social dysfunction. So let's look into the triggers. You can see again the trigger is like a sun, abnormal body sensation or a normal body sensation, which are misinterpreted. If they start having changes in appearance, imagine they see some small swelling, they believe that they have developed a cancer. Changes in functioning, suppose if there is a loss of energy or maybe a fatigue, they believe that something is going wrong because of stress, death of a family member or a closed one, or maybe a death of a film actor. They also believe that they may develop similar one. Learning about any illness, like they start reading about an illness and then they feel that yes, I may also have this illness. They start getting repeated thoughts and images. Suppose they are close to somebody and they have certain illness, they also believe they may get this. And also many a time proximity to things and threatening that they may develop this illness, they also, these are the health related anxiety which triggers hypochondriasis. So these are the various trigger, internal trigger or the external trigger can cause hypochondriasis. Now once it causes, what are the factors that maintain and increases hypochondriasis? You can see interpretation of bodily sensation, and once these sensation starts coming, they starts looking out for the symptoms. Oh, I may have this symptoms, I may have that symptoms, I may have this sign. They start doing internet search or they start looking for medical literature. They start doing doctor shopping. Many a time they have poor insight, and even the doctor says you don't have any problem, but still they believe they have illness. And they start having safety behaviors like lab investigations, asking for reassurance, going and meeting specialists from one city to another city. And many a time they have intrusive images of being cancer patient inside the hospital, suffering. The doctors are coming, relatives are coming and seeing them. These kind of images starts appearing to them and they become very distressed. So what are the safety behaviors these hypochondriasis people will have? Doctor shopping is one common. Lab investigation, many times they do investigation. Online literature search, Googling or maybe AI based chat GPT search, reading medical books, arguing with the doctor on their diagnosis. They say that, doctor, you are wrong. You need to do the investigation, asking for reassurance. Do you think I'm not suffering from cancer? Maybe many times checking for signs and symptoms, palpating by themselves, standing in front of the mirror and seeing whether they have any tumor or not, becoming hyper vigilant about any sensation that happens in the body, and also many other things they will have. Although the doctor and the investigations are said normal, they start doubting. They will doubt whether the blood was interchanged with somebody else, or else this report which has been given to me is somebody else's report, maybe the same name, or maybe the lab person has mislabeled, or else they believe that the doctor has missed the diagnosis, or else the current scientific technology has not been able to detect my illness and I will die. So these kinds of thoughts will go on and they believe that they have a severe illness, that is hypochondriasis, that is fear of having illness. Now let's enter into the CBT, that is proper. So you now know the background of hypochondriasis, that is fear of having an illness. They have safety behavior, they have avoidance. And now let's see how the CBT is done. CBT for hypochondriasis is structured therapy which lasts from 16 to 20 sessions in an ideal situation, but many a time the person with hypochondriasis will have depression, may have personality disorder, they may have substance use, then the sessions may be 30, 40, it may increase. And each session usually lasts for 45 to 60 minutes, and one session per month, per week, and over a period of time it can be spaced out. A session a month can be done. And please remember, CBT is a training program. That means in a week, there is a one session. In that one session, the therapist will train them regarding the thoughts, emotions, and behavior. Once he learns in the session, after going back home, remaining 6 days and 23 hours, he needs to implement and do homework assignment. That means it's a training program. CBT is a training program of maybe 16 to 20 sessions and implementing it. That means it is a collaborative effort between the therapist and the patient is an active collaborator. If the patient does not have any motivation to do CBT, he will not improve. So the patient's motivation, patient's homework assignment, what is the compliance, patient's cognitive capability, insight into his illness plays a crucial role in the CBT prognosis, my dear friends. Now let's look into the different steps of CBT in hypochondriasis. Starts with intake session. This intake session in hypochondriasis is a structured session between the therapist and the patient, and it's the first time they are meeting, and he has to know where the patient has been referred and what is the expectation of the patient, what do they want, and what is their engagement and how much they are able to come in a week. And also you need to tell them there is assessment and number of sessions is required. This collaborative planning and CBT is a training program that has to be told. And also the main purpose of this intake session is to establish a therapeutic alliance between the patient and the doctor or the therapist. And once, to some extent, the therapist is able to understand and set the initial treatment goal, then the therapy starts. Further, in this session, you need to structure, ask for initial problems, discuss about the expectation of the therapy, what is the role and responsibility of the therapist, role and responsibility of the client, and if you are going to include the family members, especially in India, in Southeast Asian countries, invariably the family member will be acting as a co-therapist who is educated, and many a time patient gives consent. They become a very important resource, and they will monitor when they go home. As I mentioned, CBT is a training program in India where we train the patient and the family member, and the family member will monitor how he is doing. So this collaborative work between the patient and the therapist and a family member as a co-therapist plays a crucial role. In this process, what happens, the patient not only get benefit by CBT, the family member will undergo psychoeducation, education about the hypochondriasis, how to deal with the patient, how to do cognitive retraining, how to monitor his activity scheduling will occur. Further, you need to discuss about session duration and frequency, contact details of the therapist and the patient, consent from the patient, payment details, and also you need to introduce the what is CBT. What is CBT means you have to explain to them in a brief, and if required, give certain brochures, some videos, some textbooks, or maybe books which are available online so that the patient and the patient family member reads. And many a time, if the patient is unable to come, what is the process of telling that he is unable to come and communicate to the therapist, and at the same time if the therapist is unable to do the therapy because of various reason, how to communicate to the patient. So these will be discussed in the first session. Moving to the second, baseline assessment. Baseline assessment is very essential to know whether the patient is having hypochondriasis or whether also any comorbidity. Like detailed psychiatric assessment, I have done a separate video on detailed assessment of psychiatry and also separate video on hypochondriasis. Try to get collateral information from all possible sources to know about the patient personality, patient current symptomatology, and what is the impairment, chief complaints, duration, onset, and history of presenting illness. Further, look at what are the predisposing factors for hypochondriasis, what is precipitating factor, perpetuating factor, and protective factor for depression or maybe hypochondriasis. Is there any family history, past history, personal history, and premorbid personality? Further, you need to clearly ask for hypochondriasis exploration, why he has got the symptom, what are the triggers, what are the safety behaviors, any avoidance, look for comorbidity, doctor shopping, what are the investigation done previously, what how much investigation he has undergone, what does the patient know about his symptom and what he diagnoses. Look for diagnosis and look for comorbidity, is there any medical illness that has to be checked, and mental status examination, cognitive ability, and insight. So this does the basic assessment of the psychiatry and also hypochondriasis and comorbidity. Once the assessment is done, you are clear the patient has hypochondriasis and comorbidity. Think about what to focus. It is hypochondriasis is the primary, then focus on primary. But if the patient has hypochondriasis and also severe depression, then you will not focus on hypochondriasis, you will focus on, on depression. That means based upon the patient's primary concern, you will focus the therapy. Moving to the third, goal setting and psychoeducation. Goal setting is very essential in any therapy. It can be psychodynamic psychotherapy, it can be CBT. Here, goal setting in life, what do the patient want to become in life? Like he wants to become a IT professional, he wants to become an astronaut, or he wants to become a teacher. That you need to ask and see. If you want to become that, fine, we are here to help you. Goals in therapy. Like you may say, I want to get rid of this hypochondriasis, I want to get rid of this cancer. So then long-term goal and short-term goal. Long-term goal is getting rid of this hypochondriasis, or maybe he says cancer. Short-term goal is slowly you to discuss. If you want to get rid of that, you need to attend the therapy regularly. You need to do homework assignments. You need to do certain things which we are going to discuss. So long-term goal and short-term goal. So sometimes these goal settings may become very general. The patient may say, I want to earn 1,000 rupees, or maybe I want to earn $1,000, or maybe $1 million. Then you need to ask, okay, that is a very, very general statement. Now you have to say that, okay, to earn that, what you have to do now? I have to get a job. To get the job, what is happening? Sir, I'm suffering from this problem. So to get out of this suffering, what you have to do? So that means you are coming from general goal to specific goal. That is the reason you need to have a smart goal setting. Yes, is specific, measurable, attainable, relevant, and the time based setting. That is, goal setting has to be done. This is very essential in any psychotherapy, my dear friends. And you need to educate about hypochondriasis. What is hypochondriasis? What is the symptoms? Why there is a sensation? And the belief that they are suffering from severe illness. What is cognition? What is behavior? What is physical sensation? What are maintaining factors? Safety behaviors? All these needs to be done. Many a time in one session, it is very difficult to convey them. In such a scenario, you may have to give education material. Either it can be a brochure, it can be a PDF online, you can send it WhatsApp, you can send certain videos recorded, or somebody else recorded, like this video can be sent to them, so that the patient and the family member will go through that and they learn about hypochondriasis. Once they know about hypochondriasis, then the treatment, whether they should do only medication, psychotherapy, or combination of both. So that needs to be discussed. Now moving to the four, understanding the relationship between CABs, that is cognition, affect, that is emotion, behavior, and physical sensation. It is a quad CABS model. This is what we have proposed, which is available online. CABS model is the one which is cognition, affect, behavior, and physical sensation. So all are interrelated, my dear friends. That is, if there is a cognition, what is the cognition in hypochondriasis? If there is a sensation, that sensation is a symptom, means a serious illness. That's what the patient believes. Doctor can miss a serious disease in me. Medical test cannot be fully trusted. It can be a new illness. The medical science has not gone to that level. They are missing a serious illness in me. I must keep checking my body, otherwise there will be a cancer. Not knowing what illness I am suffering is, I am unacceptable. It is intolerance. My anxiety is a sign that says that something is very wrong in me. I have a serious illness. If I come to know about this illness late, then it will be a death. So these kinds of cognition will be there. That is, misinterpretation of this physical symptom is a classic of hypochondriasis. Because of these cognitions, they will have different emotions like anxiety, nervousness, fear, frustration, irritability, sadness, mixed anxiety, depression, feeling of dread, panic attacks will be there. Physical symptoms: palpitation, blushing, trembling, sweating, dry mouth, dizziness, loss of concentration, unable to focus on work, breathing difficulties. So these are all physical symptoms. These, although they have a primary physical sensation, along with these sensation will cause more worse to the patient. Further, they have various behaviors: restlessness, avoidance, safety behavior, doctor shopping, lab investigation, doing physical examination on their own, fidgety, reassurance seeking, drug abuse, alcohol use, abusing family members, abusing doctors, putting case on doctors for not diagnosing, or giving complaint against the doctors or the other people. So these kinds of behavior also is very well known in hypochondriasis. Once the patient understand the relationship between cognition, feeling, behavior, and physical symptoms, now you need to teach them to capture them. That is hypochondriasis diary. Whenever there is a trigger, suppose if the patient has some sensation, immediately what are the thoughts he gets? What is the feelings? What are the safety behaviors, or what are the behavior he did? And how much is his feeling? That is rating 0 to -10 and +10. -10 is severe negative emotion, +10 is good emotion. Let's look into one of them. If the patient develops headache, he starts believing he has a brain tumor. That is his thought. I may have a brain tumor. I have a brain cancer. Next, anxiety, frustration, sadness, panic attacks because he has a brain tumor. That is the belief. He will go to doctor. He will get the CT scan done, MRI scan done, but still he is not happy. He may believe that there may be very small, which is not captured on the MRI, or it may be 1 or 3 cells only. Maybe in another 1 month it will become tumor. So these kinds of reassurance seeking, doing one or many times CT scan, getting exposed to do MRI many times, those are all the safety behaviors. What is the feeling? -10. He's very anxious. He's very depressed because of this. So this on day-to-day basis, he needs to track the sensation, track the thoughts, track his maybe safety behaviors. All these he has to do. So by doing this hypochondriasis, we are able to get the thought pattern. You'll be able to understand what is his sensations, what is his catastrophic misinterpretation, what are safety behaviors, and what are avoidance. By knowing this, we will be able to move forward. Moving forward is behavioral exposure. Once you are able to do this thought diary, that is hypochondriasis diary, for a period of 2 to 3 weeks, on daily basis, he's going to capture his thoughts, emotions, his anxiety. Then you get a repetitive pattern. The patient is having a similar thinking pattern. Now you will start doing behavioral exposure. But the patient should understand the rationale for exposure. Without explaining the rationale, don't force the patient for exposure. Here in hypochondriasis, you need to tell them. By doing avoidance, invariably, the hypochondriasis will become chronic. At the same time, safety behaviors like reassurance seeking, repeated checking, repeated investigation, repeated doctor shopping, doing internet search, all these will cause hypochondriasis to be there for chronic. That needs to be explained. Further, you need to tell them about exposure. Repeated exposure and not doing avoidance and safety behavior will cause habituation. Giving variance example. For example, if a patient is afraid of dogs, then what to do? He will avoid all the roads wherever there is a dog, or he believes that in this street there is a dog, and then he will not go there. So, then what to do? In such a scenario, you need to put the person in a room along with a small dog. It may be a 2 months old dog or a 3 months old dog. The patient may be very anxious, but looking at the small dog, he may not have anxiety to that level. Next, you replace the dog maybe after 1 week, replace the small dog with maybe 1 year old dog. And after again 2 weeks, replace it with 3 year old. So by doing this over a period of time, the patient realizes that all dogs are not harmful. There is only 1 or 2 dogs may be very harmful, they may bite. So by doing this habituation, he'll be able to get rid of this anxiety regarding dogs. So similarly here, the dog is hypochondriasis in this place. So here you can see the graph, you can see health anxiety and time duration. Whenever there is a trigger, or the exposure to a trigger, the anxiety picks up. Once the anxiety picks up, invariably they will do avoidance, they will do safety behaviors, going to the doctor, doing doctor shopping, going online, doing Google, searching on literature. By doing this, the anxiety comes down, but it becomes a vicious cycle. So, what to do now? In therapy, in exposure, he should stop doing avoidance. he should stop safety behaviors. So the temporary relief will stop, habituation will start occurring. By doing this, the habituation starts picking up. By once this habituation increases over a period of time, the anxiety for that health related concern will come down. So you need to specifically give in writing in his diary. Like I do this most of the time. What I do is I'll write in their hypochondriasis diary, no doctor shopping. You will not go and visit any doctors now. No discussion about your health related matters with anybody else. Invariably, hypochondriasis patients will go and tell everybody that I'm having this illness. Doctors are unable to diagnose. Do you know any good doctor? Shall I go to Ayurvedic doctor? Shall I go to homeopathy doctor? Shall I find a religious healer? So they do go on discussing. So you have to tell them stop that, because that is a reassurance. You need to tell them no literature search on medical, no Googling on about their health concern, no AI related discussion. At the same time, you also should tell them no checking the body for self symptoms or signs, no investigations, no seeking reassurance. By doing this, he will start having habituation. He will tolerate this bodily sensation. He will tolerate this anxiety, and he will, over a period of time, he will comes to know that these sensations are not pathological. Not catastrophizing it does not mean that they are suffering from severe illness. These are all sensation. These sensations need to be ignored. That they start learning. So here, by showing this graph to the patient, you can say the intensity of anxiety without doing any avoidance, without doing any safety behavior, the exposure, the anxiety will be severe. Second exposure, it decreases. Third, fourth, fifth. By sixth week, the anxiety will be minimal. This is how you need to explain the patient regarding the behavioral exposure. First, you need to do interoceptive exposure. What is this interoceptive exposure? Invariably, some patients will have, some of them may say, I'm having heart attack. In such patient, you need to provoke something called as panic attacks. What to do? That is, these patients will have fear of physical symptoms. That physical symptom means they have heart attack. So you need to induce those physical symptoms. How to do that? Here, you need to induce palpitation. How to do induce? Ask him to run. Ask him to climb stairs. Once they have this palpitation or they are choking when they are running, they will have this palpitation and choking. They start believing that they have a heart attack. Because of this, because he is running, but he believes that he is having heart attack. So his misinterpretation of this palpitation. This further increases his anxiety. More anxiety because he believes that he's having heart attack. That increases palpitation. He will do avoidance or safety behavior. He will run towards the cardiac center and gets the ECG done. So now you have to say, stop doing this avoidance, stop doing safety behavior. That is running to the doctor. So here, this interoceptive conditioning means you are going to expose him. And this over a period of time exposing, this misinterpretation start decreasing. So what are the things you can do for interoceptive exposure, especially for a patient who believes that he's having heart attack? Running in a place, walking in the stairs, hyperventilating, spinning in the chair. That causes dizziness, and sometimes it may provoke panic attacks. Then once he comes out of this habituation, you can challenge those misinterpretation. Before this, you thought that you are having heart attack. Now, yeah, I know this is just a increased heart rate. It is not heart attack. So that kind of challenging also done parallelly. So here, you need to identify the sensation and expose him to the sensation, challenge this catastrophic belief that telling that I'm having, challenge it, and then he needs to accept it, observe the sensation over a period of time, observe his cognition, and then he's be able to come out of hypochondriasis. Suppose if the patient says that I'm having a cancer in my stomach, how to expose for that? Then you have to start a imaginal exposure, because you will not be able to make him run or do anything. So here you have to ask him to imagine that you have gone to a hospital, you have met with the doctor. Doctor said that you are having a serious diagnosis. It is more of like a paradoxical therapy here. You need to make him understand and say this is an exposure, exposing him to a condition, telling that you may have a cancer. Imagine you are having a disability, you have been operated, there may be a death. The doctor may say you may have a 3 months. So these kinds of imaginal exposure, and then not doing any investigation and not allowing him to go and do any Google or interpret or doing any AI based search. By doing this, you are going to cause habituation to him. Further, sometimes you may also ask to do in vivo exposure. What is that? Ask him to go to a cancer hospital. Ask him to sit there, visiting the hospital, visiting a diagnostic lab where the patients are coming and giving blood, sitting in a clinic and observing the patient going and here and there. That triggers the thought, I may also have cancer. Or asking him to read a medical label telling that beware of cancer, check your cancer, being around a sick people, watching certain health related programs. Imagine if he is having a fear of cancer, then you have to show that. If he's having a fear of stomach cancer, show him that a documentary on cancer. So by doing this in vivo exposure and not allowing him any avoidance, not allowing having any safety behavior, the habituation occurs over a period of 3 to 4 weeks. But please remember that you need to explain the rationale for exposure. Without that, don't push the patient further. Sir, many a time the patient may say that I may have a rare illness like rabies. What to do? Then you can't expose him to a rabies. You don't have a rabies hospital. Then you need to do a audio exposure. How to do this? Ask him to write a script telling that I had gone to this place, there was a dog bite, and I went back. I did not get any vaccination, and now I have gone to this place. I'm having these symptoms. Write in detail. In detail, he will write about this anxiety. And see, if he is going there, his mother is crying, and he is walking down the aisle. People are looking at him. That a detailed. It should be like a movie script when they reveal a hero, how they show the environment. That similar script has to be written. That script, once he is written, the therapist has to go through it, see whether there are any safety instruction written there or avoidance instruction written, that to be removed, make it more dramatic. He will do audio recording in his phone and he will listen daily 10 to 20 minutes, maybe 3 to 4 times. By doing this, he is exposing himself to those dreaded fear, that is having rabies, having HIV. So, by doing this audio exposure, my dear friends, habituation occurs over a period of time. No avoidance, no safety behavior. Suppose if the patient is having severe anxiety, he is not able to relax at all, then you may consider JPMR. This JPMR is Jacobson's progressive muscle relaxation. It may be breathing, it can be yoga, pranayama, meditation. So, anything which reduces anxiety. But, however, many of the researchers say that if you do this relaxation technique, it may come in the habituation. Hence, this relaxation needs to be weighed based upon the patient's request, requirement. If the patient is able to tolerate the anxiety, it is very good. If he is not, then you may have to consider relaxation technique. My advice is avoid relaxation unless the patient anxiety is coming in the way of therapy. Then only you do this, because you need to decide a relaxation technique based upon the case by case basis. It is not for all patients I will do relaxation. Don't do that. You need to see if the patient is able to tolerate. Habituation occurs, the patient will be cured of hypochondriasis. So in such a scenario, use relaxation based upon the case base. Now enter, when he is doing this exposure, start looking for the cognitive dysfunctions. It is cognitive distortions. The commonest is, as I mentioned, catastrophization, misinterpreting the bodily sensation to a severe fatal illness, overestimation of threat. There is something sensation, that means he is going to have a serious illness. Almost catastrophization and overestimation of threat may be similar. Misinterpretation of bodily symptoms and sensation, selective attention to the symptom, hypervigilant. I am having cough means I am having a cancer, that is lung cancer. Being hypervigilant about that, intolerant to uncertainty. Sir, I am not finding the cause for this cough. Many a time you may not find the cause at all. It is physiological in nature, but the patient is very very anxious because he's uncertain. This uncertainty causes intolerance, that intolerance causes anxiety, that anxiety further causes misinterpretation and further worsens hypochondriasis. To teaching to tolerate uncertainty is a very important component of hypochondriasis. Further emotional reasoning, confirmational bias, seeking illness, confirming information, jumping to conclusion, telling that if I have this means I am having cancer. All or none, either I am extremely good healthy or I am having a seriously ill person that in another 1 week I am going to die. Reassurance seeking, availability bias, telling that rare illness is common in me. So these kinds of cognitive distortions are common. At the same time, cognitive schemas are also well known, like vulnerability to illness, telling that I'm very weak. I am from a rural background. Diseases are common. In my neighborhood, the people died because of this illness. My body is very fragile. Fragility schema, threat schema, that the world is very unsafe. Anybody can get this illness. The water is being polluted. The air is polluted. Cancer is common. This threat schema, catastrophic schema will be there. These symptom means I am having a serious illness. So these schemas are like intolerance to uncertain situation means that I'm going to have a severe illness. A health responsibility schema, that I must constantly monitor my health, otherwise nobody will monitor. That means it is my responsibility. Mistrust on the medical doctor and believe the doctor has missed the diagnosis. Doctors are human beings. The lab is also missed the diagnosis, not trusting it. Low coping skills. These are also very well known. With this, they develop automatic negative thoughts. Symptom based. This symptom means I'm having serious illness. Normal people don't feel this. I am abnormal. That means abnormal means I'm having a serious illness. I'm going to die. This is a warning sign for a severe illness. I'm going to die in a 1 week. The doctor may have missed something. That is medical related. Test can't rule out everything. There is some test which is not been come now, but I am missing. In America, it may be there. I have one patient who used to come and say that I have a brain, uh, maybe infarct or a brain tumor. When we did MRI, there is nothing, but he believes that no, no, no. The the resolution of the MRI is very poor. It is only 5 Tesla. It should be 15 Tesla. He goes on arguing. He says that I have found that there is a research based MRI in Israel or maybe in America. I have to go there. He starts pestering his family. Please book the ticket for to America. These kinds of continuously medical related test can't rule out everything. I have to go there. There sometimes they start reading something future oriented. This means this will get worse. If you don't spend 10 lakh now, you may lose me or you may have to spend 10 crore. These kinds of argument will be there. Control, I am not in control. I am not controlling this symptom. I need reassurance or I need to be with the doctor. My house should be next to the hospital. I'm ignoring the dangerous symptoms. So these kinds of automatic negative thoughts are well known, and sometimes emotional meaning, this if I'm an anxiety means I'm having this illness. So these intolerance, these kind of will trigger automatic negative thoughts. So the hypochondriasis, as it becomes chronic, if there is a symptom, that means I'm having cancer. That is the automatic symptom, death. Symptom, illness. So this is how the automatic negative thoughts. Now moving to the eighth one. This is one of the challenging part, that is challenging the dysfunctional beliefs. How to challenge by using Socratic questioning. I have done a separate video on how to do Socratic question in a CBT. CBT playlist is available on my YouTube channel. Please go and watch that. Ask for evidence, evidence for his belief, evidence against his belief. So you need to challenge that. Sometimes you have to do decatastrophization. I will teach that how to do that in a short while, and also ask him to generate alternative and say whether this is possible, whether your coughing is can be because of allergy. So giving alternative is also is possible. So also you need to challenges probability of estimation. He may say that if I cough means I'm having 100 70% I'm having cancer. So then you say, ask him, see, there are many people are coughing, that means do they have also cancer? So you need to challenge by various means. It can be pie chart. Then you have to ask all those questions. So you need to challenge, like if he has a misinterpretation of bodily sensation, you need to ask what are the evidence for telling that he has a severe illness, what are the evidence against it. And then challenge him and say, okay, you go and now sit in the hospital and see whether you get this illness or not. So that is, you need to challenge. And also you need to ask for realistic estimate. Imagine if there are 1 lakh people, if they are coughing, how many of them may have cancer? So by showing that, you have a pie chart probability estimate, that is one CBT technique that can be used. Many a time the patient may have intolerance for uncertainty. In such a scenario, you may have to tell, see, you have a cough. It may be cancer. By doing this, you ask him to tell that we are doing habituation. Now you have to not to do any safety behavior, and you need to tolerate this uncertainty, because life is uncertain, my dear friend. The certain is we are born. Uncertain is when the death is going to occur. Death is certain, but uncertainty is the problem. Similarly, in hypochondriasis, he knows he's going to die, but he is worried about this symptom and misinterpretation of this symptom. So learning to tolerate uncertainty is one of the important skills. So sometimes you may ask some questions. What is the evidence for? What is the against evidence to it? What are the chances it's going to happen? How then once he is able to do exposure, then you ask, before you entered into the exposure, what was your thinking? After exposure, what were your thinking? Before exposure, how much was the anxiety? After exposure, what was the anxiety? And then, what if this diagnosis is true? So what is the other question? So what if and so what is the exercise is decatastrophizing drill. This you need to prepare the patient, prepare the family member, and start this. This is like a paradoxical therapy. What if, so what? What if your diagnosis, what you said is true? Then, so what? Yes, I have developed cancer. So what? No, I may die. So what? Everybody will die. So, this kind of decatastrophization. What if? That there is a chain of question. Yes, this is a symptom. So what? Yes, this may be a maybe a cancer. What if it is a cancer? So you provoke. What if you get a cancer? What if the doctor has missed the diagnosis? So what if he has missed the diagnosis? You go on asking until absurdity or acceptance comes into picture. Or else he says, yes, everybody is going to die. I also will going to die. So, but today I am healthy. There are only minor symptoms, but there is a scan has been done. Then there is no symptom. So this kind of decatastrophizing drill has to be done only in a patient who is able to cope. Don't do in a patient who has a poor coping skills, my dear friend. How do you know he has a poor coping skill? If he's attempting suicide, deliberate self-harm, drug abuse, alcohol use, that don't use this. If the patient is ready, if the patient is ready to do exposure, if he is able to have a good cognitive sophistication, then only you do this. And sometimes you may ask him to do think of worst scenario. Identify what if it has been happened. So what it has happening. So this is how you are going to do decatastrophizing deal. That is by exposing imaginarily to a anxiety provoking situation, keeping him in uncertainty, keeping asking him not to do any safety behavior. You will stay with that anxiety. By doing this over a period of 3 to 4 weeks, his anxiety will come down. That will help him to deal with uncertainty also. So invariably he says, I am uncertainty is a signal for danger, is the way they believe. Now you say you are uncertain since 3 months or 3 weeks and you don't have any cancer. By doing this, you'll be able to help the patient to come off hypochondriasis. Next one is, many of the patients will have chronic hypochondriasis. Problem solving will be a big issue. Then you need to discuss about problem solving. What there is a problem, then is it a real problem or is it a imaginary problem? If it is a real problem, then you need to discuss and say that what are the possible solution. Each solution, what are the best positive uh, way of solving, what are the negative things if he has chosen this. That means for every problem, what are the different solution? For each solution, what are the pros and cons to be done? And finally, choose it and evaluate it and implement it. So teaching problem solving is very essential with many of these patients. Once he learns problem solving, then he will become empowered. Now you have done maybe around 12 to 14 sessions. Start discussing about weaning of sessions and relapse prevention. Start discussing that number of sessions has been done. Only there are another 4 or 5 sessions. Start spacing out. Now we will not see weekly. We will see maybe monthly once. By doing this, you will tell the patient may become anxious. You say, we are doing therapy to make you empowered, make you autonomous, become independent. For that, we are doing therapy. That means this CBT is not endless therapy. It is a therapy to empower the patient. You have to educate him and say that you have undergone this therapy, you know how to do this, you have undergone training. That is the word you have to say. You have undergone training, now you have to implement. Yes, you have a family member who will implement, and you have to space out the session. Maybe initially monthly once, and then 2 months once, 3 months once. And then you need to do a relapse prevention, see what are the early signs of relapse, when he has a trigger, what are the other triggers, and where the help is available. Find an high risk situation, ask him to undergo the exposure. By doing this, weaning and relapse prevention becomes stronger. The more he challenges by exposing, then he is becoming more and more empowered. And you need to tell him, ask help from the family members, ask help to challenge him. And the person who is a family member is a co-therapist can play a crucial role here, so that the patient becomes autonomous, the family becomes autonomous. Today may be a one thought about a cancer, tomorrow he may get a rabies thought. So this hypochondriasis may jump from one illness to another, so that he gets empowered by doing CBT, and relapse prevention occurs, my dear friend. And finally, the consolidation, a review of the diary, ask the patient, see, in the maybe around 3 months back when you started coming, this is the anxiety, these main thoughts were there, this were your illness related. Now, how much you have improved, why you have improved. Do the rehearsal, ask for a key points, and also plan for ongoing support. When is the booster session is available, and if he has a relapse, where to seek help, where to ask help. If there are any self-help group, refer to them. By doing this, you're consolidating the gain, and ask the patient that you need to become autonomous. The help is available, but you should learn to walk alone along with the family member. And then the booster session. Booster session maybe once in 3 months or 6 months, maybe once in a year. Look for any relapse signs, look for any comorbidity. Uh, Ask him to again focus on continuing exposure, and motivate him to engage in exposure behavior, and empower him and support autonomy, because CBT is a structured therapy, and the patient has to become autonomous. As I mentioned, it's not an endless therapy, my dear friend. To conclude, CBT for hypochondriasis is a times limited structured psychotherapy, 16 to 20 session in an idealistic way. But if there are comorbidities, personality disorder, many sessions may be required. Each session lasts for 45 to 60 minutes, one session per week initially, later it can be spaced out. Please remember, in India and Southeast Asia, CBT is a training program. He will undergo 1 hour training program per week, and then remaining hours at home, remaining 6 days and 23 hours, he will implement what he has learned in that 1 hour. And hypochondriasis diary is very essential, and tracking of his thoughts, emotions, symptoms is very essential. And once we are able to know his thoughts, his repeated pattern of cognitive distortions, schemas, and automatic negative thoughts, start doing audio exposure, imaginational exposure, in vivo exposure, challenge his thoughts, challenge his cognitive distortion. If required, start doing catastrophizing drill, what if and so what is the best way to challenge, and help him to become independent, and teach him habituation. By doing this, my dear friend, he becomes empowered. The family becomes completely empowered with to defeat hypochondriasis. This is about cognitive behavioral therapy for hypochondriasis. Thank you very much for giving your valuable time. Stay safe.